Our dear friends, my dear colleagues, ladies and gentlemen, good day. Welcome to join this virtual meeting, TTT at TCTAP2022. I'm Dr. Yi Zhangxue from Chang'an Memorial Hospital, Taiwan. Today, it's my great honor to deliver an opening remark for this meeting. At first, I would like to express my sincere thanks to the organizing committee of TCTAP for inviting TTT to join this meeting. As we know, the collaboration between TTT and the TCTAP has been maintained for many years, and the relationship is very close and good. Through this platform, we can learn the new information and share experience with each other. Today, in this session, we will talk about a strategy in CHIP patients. That is complex, high-risk interventional patients or procedures, including patients' comorbidities, complex coronary disease, or other heart disease, and hemodynamic compromise. Generally speaking, it means high-risk interventional procedure was performed in high-risk patients. Therefore, we will talk about the PCI strategy in unprotected lemon bifurcation lesion, in patients undergoing TAVR, in patients with heart failure, imaging-guided complex PCI, and after lemon stenting, how long a dual antiplatelet therapy should be used. I think all the topics are inspirative and educative for all our audience. In this section, I will co-moderate with Professor Xianli Gao from National Taiwan University Hospital and Professor Dianping Cao from Zhenxun General Hospital. At first, it's my great honor to introduce the first speaker, Dr. Xulong Ren from Zhenxun General Hospital. He will talk about the PCI strategy in unprotected lemon bifurcation lesion. So let's give a warm welcome to Dr. Ren. Thank you. Dr. Ren, please.
So today I will talking about the PCI strategy in the unprotected lemon bifurcation lesion. So the incidence of the lemon disease is reported around 5 to 7%, and more than 80% of stenosis involve the lemon bifurcation. So the lemon generally account for more than 50% of total myocardial mass. The lemon PCI is associated with a high risk of procedural complication and long-term adverse outcome, including the target vessel failure and the target lesion revascularization. The side branch is often circumflex and ramus, which generally has a large diameter and its angulation. So it makes it difficult to assess with a guide wire and supply large myocardial territory. So right now, we almost accept as Medina the classification for the bifurcation. So most of the true bifurcation, including the 111 and the 011. Some papers also accept the 101 as a true bifurcation, but the most paper only including the 111 and the 011 as a true bifurcation, and the true bifurcation almost involve more than 50% of the case. So the 2018 the ESC guideline for the myocardial revascularization still recommend lemon disease with a synthes score of less than 21 as a class 1 indication for the PCI. For the synthes score of around 23 to 32 is a class 2A indication for the PCI. The 2021 the ACC/HA guideline also consider recommend the PCI is reasonable to improve the survival and recommend as a class 2A indication. So how to general approach the true bifurcation standing? This paper published the fifth consensus document from the EBC. They suggest the PCI for the bifurcation standard should adhere to the KISS keep it simple and safety, and the systemic 2-wire, and try to limit the number of stand and to sure where expand the stand and limit the overlapping. You can use the IVAS image. So how about the one stent or two stent strategy? And we can see the previous paper such as COVID-2 restriction, and it showed a two stent strategy for the layman region. You have the more mass including the Turkey vessel failure and the Turkey vessel revascularization. So how about the second generation DAS? We can see the COVID-3 registration. It also showed a two-stent strategy have the high incidence of the Turkey region failure and the Turkey region revascularization. So almost the experts suggest so keep it simple and safety. But we know the PCI for the layman bifurcation is sometimes more complex because we should consider the clinical setting and anatomic relevance, such as the sizing, length, and the supply territory. And sometimes the disease is termed in a two branch also, and the plaque morphology, such as a calcified thrombus burden, also we should consider. And finally, sometimes the sharp angle and is difficult to approach the side branch. So we should also consider the guide wire or balloon stand to access to the side branch. So for this case, is a LAD Austin CTO. So when we open the LAD CTO region, but we lost the Remark. So for this case, we also induce the peri-procedural myocardial infarction. So what we should be considered for the layman bifurcation? So for the true bifurcation versus the non-true bifurcation, if we see the COVID-2 registration, and we can see the true bifurcation has more mass than the non-true bifurcation, including the event-free and the Turkey vessel revascularization. So we can see if we see the true bifurcation, including the Medina 111 and the little 11, then we can see for the true bifurcation, it has a poor long-term outcome, including the cardiac death or NI, definitely the stent thrombosis and the Turkey vessel revascularization and the mass. So why we say the true bifurcation, including the 111 and the 011, because it showed a poor long-term clinical outcome for the standing. So how about the impact of the extent of the side branch disease on the outcome follow the bifurcation standing? It's published in the CCI 2020. So if we see the side branch length, it's showed figure the number 8. And we can see it showed a linear correlation for the poor prognosis. It means that if the side branch length longer than the 10 millimeter, then we can see it increase the mass, the incidence is shown just like the green bar. So the side branch length also is a very important parameter for the layman stenting. So how to differentiate the simple bifurcation versus a complex bifurcation? So maybe we can see the definition trial. The definition trial, at first, including only the true bifurcation, it includes the Medina 111 and the little 11. For the distal layman bifurcation, the side branch diameter should be narrowly more than 70% and the lesion length more than 10 millimeter. It's a major criteria, and it also should include two minor. Then we can see it's a complex. The others it was separate to the simple procedure. So this major the criteria such as layman bifurcation, narrowly more than 70% lesion length, side branch more than 10 millimeter, and minor criteria including calcification, multivessel angulation, and the thrombus burden. So if the compare with one major and two minor, then we say it's a complex bifurcation lesion. And the complex bifurcation also show the high incidence of the mass compared with the simple lesion. So if we procedure for the simple bifurcation, the single stent is the efficiency is equal to the two-stent strategy. But for the complex bifurcation, for this study, and then it showed that maybe two-stent have the more better or equal to the provisional stent strategy. Of course, the previous definition trial is only in the registration, so we need a randomized control trial. So it's a definition 2 trial. It's published in 2020 the European Heart Journal. It just follow the previous criteria and divide the two parts. One for the complex bifurcation and one for the simple the bifurcation. For the complex bifurcation, for the definition trial, we can see the two-stent strategy can significantly reduce the Turkey vessel myocardial infarction and the Turkey vessel failure. So if we see the for the complex the lesion, bifurcation lesion, we can see the bar is show the two-stent strategy. It can significantly reduce the Turkey vessel revascularization, Turkey vessel myocardial infarction, and the Turkey vessel failure compared with the provisional stent strategy. So if we see the previous data such as the DK-CRUSH-2 trial, the long-term 5-year follow-up, it also showed the complex bifurcation. The DK-CRUSH technique have the more better clinical outcome compared with the provisional stenting strategy. So it also follow the definition, the criteria for the complex lesion and the simple lesion. For the simple lesion, the DK-CRUSH, the efficacy is equal to the provisional stent technique. But for the complex lesion, we can see the DK-CRUSH have the more better for the 1 year Turkey vessel failure rate compared with the provisional stent technique. If we long-term follow-up for 3 years, it also shows a concordant benefit for the 3-year follow-up. Compare the Turkey lesion failure compared with the provisional stent technique. So how about the two-stent strategy? We can, for the layman, the distal bifurcation, we can see also for the DK-CRUSH-3, they compare the Curog and the DK-CRUSH. And we can see the DK-CRUSH-3 also showed a better clinical outcome for the DK-CRUSH compared with the Curog technique in a mass and Turkey vessel revascularization. So of course, sometime recently we just discussed about EBC main trial is published last year in the European Heart Journal, and it also including the true bifurcation for the Medina 111 and the Lido 11, and it also divided two parts for the provisional strategy and the two-stent strategy. If we see the primary endpoint for including the death, myocardial infarction, and the Turkey vessel revascularization, the provisional technique showed equal efficiency compared with the two-stent strategy. And also the death, myocardial infarction, Turkey vessel revascularization, stent thrombosis, the both group is similar. But we see, maybe we can see the difference between the DK-CRUSH and the EBC main. For the DK-CRUSH, the syntax score is 31 versus the EBC main is 23. How about the side branch length? The DK-CRUSH is 16 millimeter, but the EBC main is only the 7 millimeter. So maybe we can consider the EBC main trial. Just only most case is related simple bifurcation lesion by the definition 2 trial, because the side branch length is less than 10 millimeter. So that for the simple layman distal bifurcation, the provisional standard technique is equal to the two standards strategy. So this flow chart for the unprotected layman region. Of course, the how-to definition definitely is a significant layman. We can use the angio or FFR less than 0.8 and the IVAS, such as minimal lumen area less than 6 millimeters square. Don't forget for the syntax score higher than 32, the cabbage almost is a class 1 indication. For the layman, the bifurcation region, maybe we can follow this Asia intervention published last year. For the layman distal bifurcation region, we should use the Medina classification. If the patient is 111 or 011, then this is a true bifurcation. If the patient is not a true bifurcation, then maybe it's not true or false bifurcation layman. Maybe we can use a provisional standard technique. Then we can use definition criteria such as side branch diameter stenosis less than 60%, the lesion length less than 10 millimeter. And it's a simple bifurcation. You can just use a provisional standard technique. But if the patient, the layman distal circumference side branch diameter narrowing higher than 70% and the lesion length longer than 10 millimeter is a major criteria, and plus the two minor criteria, then it's a complete bifurcation. Maybe we can use DK crush technique. But don't forget for the layman procedure, we recommend use IVAS guide. It's a strong recommend, and the guideline also recommend IVAS for the layman as a class 2A indication. So finally, for the simple layman bifurcation lesion, the provisional standard is the one standard strategy. We so think is the best policy. But from the DK crush 5, the study showed the two standard strategy reduce mass and the target vessel failure compared with the provisional standard in the complex layman bifurcation. So how to differentiate is a simple or the complex? We can use a definition two trial. One major plus the two minor, then it's a complex. We can use a two standard strategy because it can reduce the target vessel failure at 1 year compared with the provisional standing. Thank you for your attendance. Thank you.
Okay, thank you very much for Dr. Zhen's very nice presentation and speech. So regarding this topic, is there any question or comment for this topic from our panelists? Dr. Zhen, I have one question for you. You presented that from the DK crush 3 trial, the results show that the DK crush, the result is better than the QLOT. And the algorithm also suggests if we consider to standing the complex bifurcation, the technique should be DK crush will be the first consideration. So in your daily practice, will you use this technique for your routine technique to treat the layman complex bifurcation lesion?
Thank you. Because there's some only the limited data compare the different strategy for the layman distal bifurcation lesion. So because DK crush 3 show the DK technique have the more long-term clinical outcome compared with QLOT, because it can reduce the target vessel failure in a long-term follow-up. And so I personally, I almost use DK crush, but I think sometimes it depends on the operation. If the operator is more skillful the pure technique or provisional technique, we think you also can choose the DK or the pure or the provisional. It depends on your personal prefer. Yeah.
Okay. So is there a comment from our moderators or speakers regarding this issue? Okay, if no more, I would like to invite Professor Xianli Gao to moderate the next speech. So thanks again for Dr. Den's very nice speech. Thank you very much. Thank you.
Thank you.
Yeah, okay. Let me introduce our next speaker. Our next speaker is Dr. Mao Xin Lin from National Taiwan University Hospital. He's going to present a talk on a situation where the patient is undergoing TAVR, but his coronary artery needs to be fixed. So, Dr. Lin, please.
Thank Dr. Paul Gao for your kind introduction. Today, I would like to share our own PCS strategy, patient ongoing TAVR. Okay, according to the previous a lot of registry, we know that there's high prevalence of CAD in patients with aortic stenosis undergoing TAVR. And we all know that the presence of a CAD will impact the outcome in patients not only receiving TAVR, but also receiving SAVR. Whether to receive the fully percutaneous or fully surgical procedure, I think that's still a controversial issue. TAVR will combine with PCI, although it's less invasive, but I think that still brings some risk to stage or concomitant to procedure. And also PCI always thought to be not provide complete revascularization as compared to CABG. And the two SAVR plus CABG, I think, although we saw that could provide a complete revascularization in CABG, but still invasive procedure, and also will double the risk if two surgical procedure combined together. So although we now expanding our TAVR into the low risk population, but we should know that in most of the clinical low risk trial that they exclude the patient with a very complex CAD, that SYNTAX score, very high SYNTAX score. So I think that in the patient with young or lower intermediate surgical risk, and also combined with high SYNTAX score CAD, I think SAVR plus CABG is still a reasonable choice for the patient. In the past 10 years, that we developed our own treatment strategy in patients combined with the CAD and significant CAD and AS. We did not routinely let the patient have another admission before TAVR. Only we mainly depend on a pre-TAVR MSCT evaluation, and then we only let the patient admission once before TAVR in the patient with we found the MSCT found a complex CAD. It means that the patient has lemon or more than two vessel disease, have thickening disease in the main trunk of dominant branch. We will arrange another cardiac class before TAVR. Besides, if the MSCT tells us that this is non-complex CAD, it means that only one vessel have ischemic stenosis or less. I think we will let in the patient, if the even have no significant CAD or none, we have to directly go for TAVR. But if we found the MSCT that one vessel disease, we are doing the diagnostic angiogram during the TAVR, and to do the PC using the concomitant procedure, depend on what we found from angiogram. Our approach to concomitant PCI only there's some rules, because we only perform PCI only in the lesion in the proximal vessel or in the vessel supplying a large territory, and the expected PCI time less than 30 minutes. Of course, that the patient has significant renal impairment, we will not the patient doing the concomitant procedure. This is an example case that the 88-year-old woman have a severe AS, one vessel disease. We found the MSCT found one vessel disease have a significant disease, stenosis in the LAD. So we doing the diagnostic angiogram during the TAVR, and we found that the LAD has significant lesion. So we're doing the PCI before TAVR. And sorry. Okay, and put standing, and that's the final angiogram. So after that, we switch to the TAVR, and this case has low coronary height, so we protect LAD with a balloon, and then there's a final angiogram. So we also can do the functional assessment when the patient, we found that moderate or borderline CAD during the diagnostic angiogram. He's an 90-year-old male, have a AS, and we from MSCT we found circumflex has a moderate disease, and RCA also have a disease. And then we do the TAVR first, and after TAVR, we do the pressure wire measurement for the circumflex, and you see that FFR is 0.8. So that's we leave it for the medical treatment. And the RCA also we do another pressure wire measurement, and you see it's still 0.9 FFR. So we still leave it for medical treatment. So this case we concomitant with the PCI and the TAVR. But if a patient have a complex CAD, and we will arrange a diagnostic angiogram before the TAVR. So if the syntax score is relatively low, we will let patient have a staged or concomitant PCI and TAVR. This is another case that the 81-year-old woman and the poor LV function, severe AS, and also have a significant mitral regurgitation. And from MSCT, we found there's a Ledman disease. So you can see that the critical severe stenosis is Ledman trunk. And then we do the stage procedure. We do the Ledman PCI with IV standby, 2-wire protection, and then we do the stenting from Ledman to circumflex, and finish with a kissing balloon technique, and that's the final angiogram. Okay, so after that, or even 2 weeks later, we use stage PCI and TAVR. We use a 29mm profile, and then final the procedure. Okay, you can see that. Okay, this is before we do the TAVR, PCI and TAVR is poor LV function and significant MR, and after that we complete both procedure, LV function improve and MR became mild. And if patient have a syntax score higher than 22 and very low, a relatively low risk, surgical risk, so we will move the patient to receiving TAVR and CABG. But if we patient have both significant complex CAD and high surgical risk, I think we still can do the patient with fully percutaneous under the mechanical support. This is another case that 86-year-old woman with a lot of vascular risk factor. This have she had ever received bypass surgery but graft failure, and also ever received stenting in the LAD with very poor LV function and the critical AS and high surgical risk. From the pre-TAVR MSCT, we found that the LAD, before the proximal to the stent, there's a significant lesion. Circumflex had totally occluded, and the distal RCA and the PLA also totally occluded. And his 2 SVG will both have both occlusion. So that's a very complex CAD for this patient. You would do the an angiogram before the TAVR. You can see that the stent is okay, but before the proximal to the stent, there's a significant lesion, and circumflex is totally occluded. And RCA, you can see that the distal RCL PLA is occluded. So we do the TAVR plus PCI under ECMO support. You can see we put in the from that groin, we put the ECMO and then do the TAVR first. So do the TAVR with second 3 valve. And then this is the final after TAVR. And then after that, we can also follow by the PCI and put a stent in the proximal LED. And this is the final angiogram for the PCI. So the patient the ECMO was removed and also extubated on table. And also she can be transferred to the general ward 2 days after TAVR and also discharged 4 days after TAVR. So I think that I conclude that the CAD is very common in patients undergoing TAVR, and the presence of CAD will impact patient TAVR outcome also for the TAVR's outcome. I think that in the patient combined with CAD and severe AS, our treatment strategy should be determined based on the CAD complexity, procedure complexity, and patient surgical risk and the functional status. Also, we need to know that the surgeons are still our good friends. I think we can, for the patient with a very complex CAD and relative lower surgical risk, CABG plus TAVR is still the preferred choice for the patient. Thanks for your attention.
Okay, thank you, Mao Xin, for a nice presentation. Do we have any comments or questions from our panelists?
Yeah, Dr. Gao, can I have a question?
Yes, Dr. Cao, please.
It was a very good lecture. And I saw at the end of your lecture, you show a case with you put the S3 first and then PCI. And if you are going to implant self-expanding valve, would you do the same sequence, TAVR first and then PCI, or you would change the sequence?
First, I think that the self-expanding valve, if you would follow the commissural alignment technique, I think we still get to TAVR before the PCI. So I think it's not a very I think urgent issue. I think still we can do PCI before TAVR or TAVR for PCI in both valve. Of course, I agree that low frame transcatheter heart valve provide better approach to the coronary access. I think yeah.
Thank you.
Okay. Do we have one more? Okay, if not, for the time constraint, I think we will move on to the next one. But Mao Xin, thank you for a good presentation. I will continue to introduce our next speaker. Our next speaker is Dr. Rongcheng Xu from Far Eastern Memorial Hospital. He will change the topic to another side, which is how long is enough for DAPT following left-main stenting. Rongcheng, please.
Okay. Thanks for a kind introduction. My name is Rongcheng Xu, and my topic is how long is enough for DAPT following left-main stenting. Recently publication, ACC and HA published the guideline for coronary artery revascularization. Looking at the details, the duration of antiplatelet therapy depends on the clinical presentation, acute coronary syndrome versus stable CAD, stent types, drug-eluting stent versus bare metal stent, or a short depth monotherapy with P2Y12 inhibitor or aspirin in high bleeding risk patient, or prolonged extended depth use in patient with lesion complexity or patient factors such as high DAPT score. So we must emphasize the need to individualize therapy on the basis of ischemic and the bleeding risk. So there is a treatment dilemma. We must balance the bleeding risk and the ischemic risk. The dual antiplatelet therapy study is a large randomized control trial to address the issue of prolonged death, 13 months versus 12 months. The study population excludes MACE or bleeding events within the first year after DS. However, in this large trial, the layman population is less than 1%. In this trial, prolonged DAP use decreased the MACE rate and the stent thrombosis risk. However, it will increase the bleeding, so it's kind of trade-off. A few years later, they developed the DAP score, including the clinical variables like age, cigarette smoking, diabetes, myocardial infarction, Texas stent diameter less than 3, heart failure or ejection fraction less than 30%, vein graft stent. If we continue the P2Y12 inhibitor prolonged use, the cenobamate, we will reduce the myocardial infarction and the stent thrombosis. The hazard ratio is 0.5. However, it will increase the moderate or severe bleeding. The hazard ratio is 1.66. If we stratify the outcome by the DAPT score, if the DAPT score is high, that means the equal or greater than 2 points. The MACE rates will be reduced if we use the prolonged DAPT. However, the moderate or severe bleeding, if we use prolonged DAPT in the same group of high DAPT score, the risk will not be increased. So prolonged DAPT may be more beneficial in high DAPT score. Efficacy and the safety of DAPT after complex PCI. Dr. Justino has published in JACC 2016. They defined the complex PCI, including triple vessels treated, more than 3 stents, more than 3 lesions, bifurcation with 2 stents, or over 60 millimeter total stent length, or a chronic total occlusion. In this trial, the complex PCI composed the layman group about 5%. In this trial, long DAPT is better than short DAPT in complex PCI, but not in non-complex PCI. You can see the panel A, the complex PCI with long DAPT is the blue line, and the complex PCI with short DAPT is the blue dotted line. So there is a significant difference in the outcome. As the number of high-risk procedural characteristics increased, that means to increase the PCI complexity, more favors to use over 12 months of DAPT versus 3 to 6 months of DAPT use. Dr. Ye has analyzed the lesion complexity and outcome of extended dual antiplatelet after PCI. So the number of complexity characteristics increased, the MACE rate will be increased, but not the major or severe bleeding. But we look into the endpoint events from 12 to 13 months. Only high DAPT score, that means equal or greater than 2 points, that make the difference of the MACE rate, but not the lesion complexity. So maybe in the long run, the patient factor play the major role in the outcome, not the lesion complexity. And Korean colleagues has published in JACC Intervention 2018, dual antiplatelet therapy duration determines the outcome in 2-stent strategy in layman bifurcation. They collect the prospective DS registry and found layman bifurcation over 700 patients, including 1-stent strategy and 2-stent strategy. For the target lesion value, 2-stent group has the worst outcome. However, if we look the DAPT interruption less than 1 year, the 2-stent group has the worst outcome. So we found that the DAPT interruption less than 1 year is the independent predictor of target lesion failure only in the 2-stent group, but not in the 1-stent group. I also want to introduce the precise depth score. It's the risk scoring system to predict the out-of-hospital bleeding. The precise depth score was calculated based on age, creatinine clearance, hemoglobin, white blood cell count, and the prior bleeding. The authors found that in complex PCI or non-complex PCI, only the low precise depth score that less than 25, the long DAPT will be better. On the opposite, if the precise depth score is high, is equal or greater than 25, that means the patients were high bleeding risk patients. So short depth is better in the outcome. In 2019, Academic Research Consortium has defined the definition for high bleeding risk. Fulfill the 1 major or 2 minor criteria who will be referred to as high bleeding risk. Maybe in the future study, we can use the same definition. And how about the long-term efficacy of extended dual antiplatelet in Lehman bifurcation stenting? Also, current colleagues use COMATE and the COPIS-2 registry, and they found that if we use the long DAPT more than 12 months, the outcome is better than the short DAPT less than 12 months regarding to MACE rate, all-cause death, cardiac death, or myocardial infarction. And from multivariate analysis, age over 75, depth score equal or greater than 2 points, chronic kidney disease are the predictors of worse outcome. However, the depth use more than 12 months is the predictor of better outcome. So what is the optimal duration for dual antiplatelet after Lehman coronary artery stenting? From the Korean multicenter angioplasty team registry, after propensity score weighting, we can see the NACE, net adverse cardiac event. The DAPT use is more than 12 months, it has the better outcome. From their model analysis, the authors proposed that maybe 15 months of DAPT is best cutoff time point after Lehman stenting. In that study era, the DAPT means the aspirin and the clopidogrel. In twilight complex, that means the compare the ticagrelor monotherapy versus DAPT with aspirin and tica. After the complex PCI, including the complex PCI defined before and add on the Lehman and the atherectomy. Lehman group is the 15% in this study. So after depth for 3 months, then use the ticagrelor monotherapy. Compared with the aspirin and the tica for 12 months, the tica monotherapy will reduce the bleeding event, but not increase the ischemic event. So optimal duration or regimen after Lehman stenting is very complicated. It depends on acute coronary syndrome, stable CAD, stent generation, or use the intravascular imaging guidance like OCT or IVUS, a scoring system, depth score, precise depth score, lesion or procedural complexity, plaque burden, especially in non-stent segment, uncontrolled risk factors during the follow-up, potent P2Y12 inhibitor, what regimen and what dosing, ticagrelor 90 or 60 milligram, prasugrel 10, 5 or 3.75 milligram monotherapy versus DAPT with aspirin and clopidogrel. De-escalation or short depth according to the bleeding risk, indication of long-term OAC in atrial fibrillation patients, triple or dual therapy, NOAC or LAA closure. So life is difficult and so is the topic. Thank you for your listening. Thank you.
Okay, thank you, Rongchen. I think you also gave us a very wonderful presentation, but maybe some of us is more confused after the talk.
I am confused too.
Do we have any comments or questions for Dr. Xu?
Yes, I have one question for Rongchen. So if we go back to the topic of this speech, how long is enough? Because from your presentation, a lot of the study compare the depth less than 12 months with more than 12 months. But the study didn't tell us how long is enough. So how about your opinion from Rongchen? How long should we give the patient lifelong or 3 years or 5 years? Thank you.
It's a very complicated question. Yeah, I think from the evidence right now, from the multi-registry analysis, we can tell that the LAMEN is like the complex PCI or complex procedure. So if the patient is not in the high bleeding risk group, we should prolong the depth use. But up to now, maybe 13 months, that 2.5 years is the evidence. However, if we use the lifelong in some patient or not the high bleeding risk, maybe it's the real world practice. Sorry, I cannot answer that question.
Okay, thank you. I think we need more data regarding this issue. Thank you.
Yes.
Yeah, I think it's a very tough topic, and we have to do our wise choices according to patient on a patient-to-patient basis. So because of the time limitation, we have to move on. I will ask Dr. Cao to introduce our next speakers.
Okay, thank you, Professor Gao. And the next speaker is Dr. Junwei Li. Dr. Li is from Mackay Memorial Tanshui Branch Hospital, Taiwan. And his topic today is PCI strategy in heart failure. Dr. Li, please start your presentation.
I'm very honored to be invited to share some PCI strategy in heart failure patients. First of all, this is a very big question since that it involves multiple conditions. For example, according to the heart failure, there are many ways to classify them, including acute heart failure and chronic heart failure. And if we divide it by the left ventricular ejection fraction, we could also separate them with HFpEF and HFrEF. Meanwhile, according to the condition of PCI or the coronary artery disease, there are acute coronary syndromes or chronic stable CAD. Meanwhile, according to the CAD, there could be the condition of the patient could be multivessel disease, left main bifurcation, or CTO. And meanwhile, there are other issues. For example, in heart failure encounters PCI, what kind of device, image device or functional device, and the drugs, and also some hemodynamic issues, including mechanical circulation supports such as intra-aortic balloon pumping or PCPS. Due to the complexity of the situation, currently there are many of these conditions that are lacked of randomized control trial. So currently our evidence are basically our indirect evidence and mostly are from observational data. But the general concept or the principle is pretty much similar with the general CAD or PCI conditions. And last year in the JACC journal, they have a JACC state of the art review, which shares some latest and concept of PCI during patients with heart failure. First of all, we know that CAD has a very high prevalence in patients with heart failure, which is nearly 2/3 of the patients. And in the United States, CAD remains the most common causes of heart failure, account for like 60 to 70% of the heart failure cases. This figure shows that the condition on the left-hand side, we could see acute heart failure, and probably we could further divide them in acute coronary syndrome and the blood pressure, whether the patient is shocked or not. And on the right-hand side, we could see the chronic heart failure conditions. And meanwhile, they have many other separated subgroups of it. And during the bottom of this figure shows that currently evidence of the published RCT data according to these classifications. As you could see on the very left-hand side, with acute heart failure with acute coronary syndrome, RCT shows that PCI could reduce all-cause death, cardiovascular death, sudden cardiac death, and further acute myocardial infarction and heart failure hospitalization. And with the mechanical circulation support during PCI, there are no evidence of RCT could show that could improve outcomes. But this is still very controversial. And meanwhile, you could see there are a lot of question marks, which means that in other different conditions of heart failure encounters PCI, we are lack of RCT data. There are a few RCTs are ongoing, which probably we could look forward to in the future, including those patients with acute heart failure with hemodynamic unstable, whether we use ECMO, implant the ECMO first, then do the PCI, compare with PCI only, or probably the involvement of Impella. And probably future RCT could tell us further more evidence, what should we do during heart failure plus PCI in hemodynamic unstable acute heart failure patients. First of all, in acute coronary syndrome plus heart failure, primary PCI is still strongly recommended in STEMI patients with heart failure, regardless of the heart failure subtype, which means the LV ejection fraction. And in ACS plus heart failure patient, they still suggest that we should consider total revascularization, especially for those patients' heart failure etiology is CAD related. But however, the PCI timing depends on the patient's condition, which means that we need to take the hemodynamic condition into concern. For example, for non-corporate lesions, whether should we treat them in the index procedure or index admission. For stable CAD patients, PCI is still recommended in the same principle with the general population, for example, stress test positive. And for those ischemic cardiomyopathy, plus those patients will probably benefit more from total revascularization. And in stable CAD plus heart failure patient, functional guide and image guide may help to achieve a better outcome. How about FFR utilized in PCI plus heart failure? Actually, there are no RCT that study FFR guide PCI versus angio guide PCI in heart failure patients. Meanwhile, there are still no RCT to tell us whether FFR guide PCI versus medical therapy in heart failure patients, no matter the ejection fraction is preserved or reduced. Traditionally, FFR is divided by the distal coronary pressure minus the venous pressure divided by the artery pressure minus the venous pressure during maximum hyperemia. However, this is usually be simplified as PD divided by PA in clinical practice. For those who have reduced LV ejection fraction, the PV probably will be a little bit elevated. However, so for those patients who have reduced LV ejection fraction, the PV will probably have a little bit slightly overestimated in the FFR value. In the FRAME study, there are only less than 10% of the study population's LV ejection fraction is below 40%, which means that in FRAME study, there are not plenty of people could show the evidence of FFR in heart failure patients. In the sub-study, for those lesions between 50 to 90% stenosis, they have a similar FFR value. For those who have 91 to 99% stenosis lesions, the reduced LV ejection fraction will probably have a higher average of FFR value, which is significant. Meanwhile, in FRAME 2 study, they excluded the patients with LV ejection fraction below 30%, which means in FRAME and FRAME 2, there are very limited data for FFR in heart failure PCI. This is the simple conclusion of this topic. CAD is a highly prevalent in patients with heart failure, and CAD is also one of the major causes of heart failure. Currently, lack of RCT evidence due to the complexity of the situation, including the heart failure subtypes and the CAD condition and hemodynamic condition as well. Current evidence mostly are based on observational studies and many expert consensus or opinion. The general principle of PCI is similar with the general condition of CAD. Revascularization is suggested for ACS plus heart failure patients, despite the heart failure subtype, especially with heart failure, the etiology of heart failure is CAD. Functional guide and image guide may improve PCI outcome in stable CAD plus heart failure. FFR value is similar in heart failure patients, but may have a little bit mild overestimated in those patients who have very poor left ventricular ejection fraction. And there are still many ongoing studies focused on the heart failure patients, and we probably could look forward to in the future. Thank you for your attention.
Thank you, Dr. Lee, for your excellent talk. Is there any question or comment from our panelists or moderators?
Yes, Junwei, I think in your presentation, the last 2 and 3 slides, the FAME study, it should be FAME study, not FRAME study, right?
Oh, yeah, sorry.
FAME. Yeah.
Yes.
Sorry, yes, sorry. I think it's a mistake of the typing. Yeah. Okay.
Yes.
Yeah, good. Okay.
So Dr. Lee, so because the PV is elevated, so if the patient had the FFR in heart failure patient with poor LV function, the FL data might be incorrect.
Yeah, because of the venous pressure will be mildly elevated in those patients who have a very poor left ventricular ejection fraction. Yes. So probably it will have a little bit slightly overestimated FFR value. Probably, for example, the FFR value, the true FFR value probably would be like 0.78, and then we'll probably elevate it a little bit, like 0.8. Yeah, so for those patients who have a borderline FFR value, probably we need to be very careful of it.
Thank you.
Yeah, I think in patients with heart failure, prior procedural evaluation of viability or ischemic burden is even more important. Because these patients, sometimes the symptoms will be attributed to the heart failure rather than a myocardial ischemia. I believe in the future, we need more precise functional evaluation, not just FFR. Like you have mentioned, there are systematic or scientific reason for it to be inaccurate, but we should look for something like PET scan or scintigraphy to make sure that the revascularization is indicated.
Yes, totally agree. There are some ongoing trial, but small studies. They are focusing on how to more precisely to evaluate whether the patient will get some benefit from PCI in heart failure patients.
Okay, thank you, Dr. Lee, for your very good lectures. So we continue to the next topic. The next speaker is Dr. Zhemin Lu. He's from Taipei Veteran General Hospital. The topic today is image-guided complex PCI. Dr. Lu, please start your lecture.
Thanks to Chief Charles, very kind introduction, and it's my honor to be here to have a speech about the use of image guide in complex PCI. I think everybody knows that the image guide PCI, especially IVAS guide PCI, is associated with a much better outcome compared to the angio guide PCI. So today I would like to focus on the use of the IVAS in complex CTO PCI, especially when the anti-grade approach or retrograde approach have failed. Okay, sorry. Okay, we know that during the anti-grade approach, we can use a wire escalation or even a power wire technique. But if we use IVAS, we can use IVAS to check the relationship of the wire and the true movement or false movement, and try to use IVAS to guide our wire family to close the CTO region. And here I would like to share my two cases for the IVAS guide re-entry wiring. And this is the first case. This case is a 51-year-old male, and he have undergo 2 failed PCI before. And we can see that the LED middle is total occluded and with a residual dissection here. And actually, they did not have a suitable retrograde collateral from the right coronary artery. So I think anti-grade approach is the main way for us to open the LED. So I think I briefly go summarize the procedure. And here now my wire, this is very long CTO. So my wire now has closed the middle LED to the diagonal branch, and use the IVAS guide side branch technique. My wire has enters more distally, and then one stiff wire has go into the diagonal 2 branch. And again, I use the IVAS to search in distal LED true lumen and try to use the double caster, double lumen microcaster, and try to puncture my wire into the distal LED. But after I struggle for 1 hour, my wire still cannot go to the distal LED. The wire looks very, very close to the distal, to the true lumen, but it cannot go to the very, very far. So I think my wire still go into the false lumen. So at this moment, I use the IVAS to check from the A plane, B plane, and 2C plane. We can see that actually there are some calcium located as a distal LED, and we can see that from the arrow we can see that some wire is located as my IVAS is in the false lumen, and the second wire IVAS is put back from the left side wire, and we can see that another wire, middle wire, is located still in the false lumen. And we can see A panel and the B panel, there is some calcium block as the junction of the true to false lumen. So if we put back a little bit higher, we can see the C panel, there is no more calcium. So I think maybe we have 2 choices again. Maybe we can give up the procedure, and this patient will receive the 3rd failed PCI. But now maybe we can try to use another stiff wire to puncture this label through a more soft crack here. So I will try to puncture a higher label, and this time, very fortunately, my wire go into the true lumen again, and then he can more smoothly go to the distal LED. We can confirm the true lumen. So after, this is his final angiogram. So I think by use of the IVAS to carefully check the plaque composition, maybe we can find the suitable position that can and definitely and delicate control my wire, it may have a more chance to go to the distal LAD. And this is the second case, very interesting case. This is a 54 years old female. Here also have the uremia, hypertension, and presented with the syncope with the PEA, almost the OCA. And the angiogram at other hospital show that the triple vessel disease, and the operator there, they do the successful PCI for the PDA and the circumflex, but they also found that there was total occlusion over the middle LAD. So they try to do CTO PCI, but they failed for three times. And this is imagery for the third time the PCI attempt. We can see actually it seems there is some connection between the LAD middle to the distal LAD. There almost the chemistry flow. And then the operator tried to wire, send his wire to the distal LAD, but he feels some great resistance. We can see that the wire curve up and then the wire not so smoothly. And finally, after some manipulation, the distal flow become to disappear. And I think in the final angiogram, you can see the distal flow is almost disappear. Also, this is the final angiogram of the third trial, also failed PCI. So I was invited to the other hospital to do the fourth PCI trial. And again, you can see there is some connection between the middle to LAD, distal LAD, and almost the TIMI2 to TIMI3 flow. But there are many residual dissection. You can see some line around the middle LAD. I think this is a residual dissection left in the previous three PCI. And there is no very suitable collateral from the right RCA to the distal LAD. So again, I use the soft wire. You can easily go to the septal branch, and then I try. I use again double lumen microcatheter, and another second wire. You can easily go to the distal LAD, but I think again go to the fourth lumen. So I check the IVAS again. If you see the IVAS very carefully, you can see that IVAS may be located in the fourth lumen, and there are some many small lumen. I think is one of it is maybe a true lumen, but actually I cannot very confidently identify where is the true lumen. So, but I try to identify the transition point of the true lumen to fourth lumen. So I identify the label, but because there is no suitable marker to guide me to control my wire. So this time, so although I try to use a stick wire, I try to puncture the entry point, but because there is no suitable guide. This time, although my wire going to the distal LAD, but I think my wire again also in the fourth lumen. And I struggle for sometimes, but still cannot smoothly go to the distal LAD. And the bad news is the LAD runoff began to disappear. So I turned to the retrograde approach. But again, as an initial way, I told you that there is no suitable retrograde. And finally, I found only very faint retrograde collateral. And but I used a Caravelle microcatheter to try to cross to the retrograde collateral, but unfortunately, the Caravelle is reused. So the Caravelle tip broken, and you can see here that the diag plug obstruct the residue, the only one collateral from RCA to the LAD. So I think this is a very bad situation. I have to turn back to the integrate approach again and try to manipulate my wire a little bit, but at this point, the retrograde has disappeared. Integrate flow is also impaired, so at this moment, patient become to feel some chest tightness. So again, I check the IVAS again, and I use the IVAS to go more distally to a little bit far to the septal branch, and we can check very carefully the relationship between the septal wire and the diagonal branch and the force lumen and the true lumen. And at this moment, we can find that the septal branch maybe has some connection to the diagonal branch, but their position, if we look at very carefully, we can see that the wire, septal wire, and the true lumen and the force lumen, they are right in one line. So at this, I think at this level, maybe I can control my wire to try to puncture in the middle between the septal wire and the force lumen. So I use my double lumen microcaster, crusade microcaster, and I use another stick wire, conquest pro wire, and try to puncture the middle of the septal branch and the force lumen wire. And this time, fortunately, my wire go into the distal LED. And check with the IVAS, we can see that the wire is located in the middle of the true lumen. And this is the final angiogram. But because the puncture label is a little bit far than diagonal branches, so I think the diagonal branch have to be sacrificed. But the distal flow, I think is the TME3 flow, maybe satisfactory result. And this patient underwent follow-up angiogram 1 year later. We can see that the stain is still pattern. So I think from this type of CTO cases, I think we know that both the anti-grade approach and retrograde approach may greatly improve the CTO PCI success rate, but in the under the circumstance of the TctAP situation, when both the anti-grade and the retrograde approach have failed, maybe IVAS check and IVAS guide variant may be useful in the treatment of this kind of the TctAP CTO PCI. So this is my two cases, and thanks for your attention.
Thanks, Dr. Lu, for your very comprehensive talk and very interesting cases of 2 CTO cases. And any question from our experts?
May I?
Yeah, yes, please, Dr. Gao.
Okay. Zheming, 2 wonderful cases. We enjoy your talk on the IVAS guided PCI a lot in the past. One thing I'd like to ask is that in these 2 cases that you had presented today, both IVAS are done and then the probe are removed, and then you start your wiring with the dual lumen catheter. So yes. In fact, probably this is not a real-time IVAS guide. Do you think it's important to have real-time IVAS guide, or what is your tips and tricks so that you can register your IVAS probe position and then you can have a very precise wiring landmark, not a real-time?
Yes, I think this is very critical critical question. I think because the device limitation, because the second case is done in other hospital, and in that hospital we also only have the volcano, but I think the volcano IVAS has some advantage because the tip is shorter, so we can check the IVAS without advance my IVAS catheter too far. Because IVAS guide wiring, if you check with IVAS in the force lumen, we always carry the risk of the perforation. So if we use the short tip IVAS, there maybe has some advantage. But we know that in Japan, experts they have the much more short tip thermal IVAS, and the thermal IVAS the profile is a little bit smaller than the volcano. I think there maybe we can do some real-time wiring, but because just like my case, there is very small vessel, maybe 2.5 or less than 3 millimeter. So in that there is not enough space for you to do the real-time wiring. But I think I have seen that the Japanese expert to perform the real-time IVAS wiring. I think we have two person. One is very experienced IVAS interpreter, and another is very experienced CTO PCI. They have to cooperate, and we may have one the IVAS interpreter to guide the CTO the operator to control their wire. at first we have to identify the tip. Where is the tip of the wire on the IVUS? And then he can identify the direction of the wire. Because we know the operator always do the control our wire by the angio. But when you do the angio, what the movement see on the IVUS. So how to correlate with the IVUS and the angio? I think we maybe need a very experienced IVUS interpreter and to guide and the operator, and there maybe have a very well cooperation between them, and then we can do the real-time IVUS. Yes.
Thank you.
I have one question.
Yes.
Yes. As we know that Dr. Cao is also the expert of ADR. So in the first case, do you think it's probable to use ADR to finish the first case?
Yes, Dr. Cao.
ADR. Dissection re-entry for first
I forgot
case.
the image of the first case. Yeah.
But I think in the first case, because the vessel is too small, maybe less than 2.5, because a little bit shrinkage of the distal LAD, maybe less than 2.5, 2 millimeter. I think it's very difficult to perform the ADR. And another critical point is that we can see from the IVUS there is some calcium distribution over the CTO segment. So if we use the ADR, also the ADR is not very helpful in calcified plaque. So I think the concept is the same. Maybe we can use the IVUS to identify the suitable point that we can do the IVUS wiring or the ADR. And the most important to avoid
imaging guidance is important. Thank you.
Yeah.
I'm just wondering, the same case with Dr. Gao I asked, and you used the volcano IVUS to check the position of the first wire and also the second wire. And after that, you remove the IVUS caster and would rewire the wire to try to enter the true lumen. But after you insert the IVUS caster, the first lumen will be enlarged by the IVUS caster. Would it be the possibility of the second wire easier going through that first lumen?
Yeah. I think this is why my first attempt in the second case, my first attempt of the IVUS guide failed, but the second time is a success, because after I remove the IVUS caster, I have to use another marker for me to guide my puncture. And from the IVUS image, we can first to identify where my puncture, the plaque is very calcified or soft plaque, and what's the distance between the true and false and the wire. I think maybe from the image, maybe we have to a little bit estimate and do some puncture, but sometimes even there is a marker, maybe the success rate is not that, maybe only one half. Okay.
Thank you. Because the time is quite limited, so I think I have to close this section. So, dear Professor Shea, Professor Gao, and all our colleagues, and this is a symposium about the chip. So we have 5 fascinating speakers made very comprehensive lectures about the chip-related topics, with the updated information from the speakers and the extensive discussion of the moderators and the panelists. We have more clear understanding in chip. So thanks TCTAP for providing TTT this excellent opportunity of having this section. And I appreciate all of the moderators, panelists, and the speakers for your contribution to this section. We just had a Chinese New Year vacation. I wish you have a very happy New Year and have a good health. Thank you. So this session is closed. Thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye.